Good morning, teachers and colleagues. I'm Dr. Chakor, medical oncologist from Pune. The abstracts I will be discussing are about adjuvant CDK4/6 inhibitors in early breast cancer. We all know that most of these patients usually do well with the current standard of care, but there are around 30% of patients with high-risk clinical and pathological features who may have distant recurrences, and many of these happen in the initial few years. So there was a need for improvement, and with the experience of abemaciclib and palbociclib in the metastatic setting, it was obvious that these drugs will be tried in the adjuvant setting as well. So the first of these four abstracts is the PALAS trial, the final analysis of adjuvant palbociclib in early breast cancer patients. This study was a prospective randomized phase 3 trial. Inclusion was all patients with hormone receptor positive, HER2 negative patients, early breast cancer were included, irrespective of stage. They were randomized to receive 2 years of palbociclib plus endocrine therapy versus endocrine therapy alone. The primary endpoint was invasive disease-free survival, and secondary endpoint included overall survival and distant recurrence-free survival as well, and safety analysis. This trial recruited around 5,700 patients over 3 years in 21 countries. The median follow-up at the time of this analysis was 31 months. As we can see, both the arms were balanced for the stage of the disease, the age of the patients, as well as whether they have received adjuvant, neoadjuvant chemotherapy or not, and menopausal status. A point to be noted over here is that almost 70% of the patients had an T1, T2 disease, and N0, N1 disease was seen in almost 61% of the patients, and 66-67% of the patients were grade 1, grade 2. So only 30% of the patients were having either T3, T4 disease or N2, N3 disease or a grade 3 disease, what we consider to be a high-risk disease. This trial showed that there was the invasive disease-free survival at 4 years was almost equal in both the arms, whether they have received palbociclib plus endocrine therapy or they have received only endocrine therapy, 84.2% versus 84.5%, and there was no significant difference. Differences were observed for secondary time to event endpoints, and subgroup analysis did not show any differences by the subgroups as well, whether it is menopausal, premenopausal, postmenopausal, advanced disease, early disease. So the curves sitting on top of each other, and the forest plot also showing that there is no difference, no advantage of adding palbociclib. So the trial concluded with the comment that it did not improve, addition of palbociclib did not improve outcomes over endocrine therapy alone in patients with early hormone receptor positive breast cancer, and that there were no new safety signals for palbociclib in this trial. The next drug, which was at the same time, Monarch-E study has been done for the abemaciclib in adjuvant setting. Abemaciclib, we know it's continuously dosed oral CDK4/6 inhibitor with more selectivity for CDK4. The efficacy in adjuvant setting has been studied in Monarch-E study. This trial recruited patients again with hormone receptor positive, HER2 negative, but they selected high-risk patients either based on clinical and pathological features, like they defined that either there should be patients with more than or equal to 4 axillary lymph node pathologically proven, or 1 to 3 nodes, but the disease should be either grade 3 disease, or the tumor size should be more than or equal to 5 centimeters. And the other cohort 2, that is yet to mature, so I'll not discuss that. Patients were randomized to receive 2 years of abemaciclib plus endocrine therapy or only endocrine therapy. Again, baseline characteristics well matched on each arm. 37% of the patients had received neoadjuvant chemotherapy. All these patients had an high-risk disease. The first of these 3 abstracts is the cohort 1, which was clinico-pathologically considered to be a high-risk disease. So out of the total 5,800 patients, 5,100 were of cohort 1, and at a median follow-up of 28 months, 90% of these patients had completed abemaciclib. There was an IDFS benefit of 5.7% at 3 years, distant relapse-free survival benefit of 4.4%, 4.5% absolute benefit. So, and this benefit was consistent throughout the different subgroups of patients and diseases. The Kaplan-Meier curve showing a significant benefit and the curve separating well at 2-year and further separating at 3-year time point. So to conclude, it was beneficial in the cohort 1. The next abstract was about what is the benefit? Are we seeing any benefit in the patients who have received neoadjuvant chemotherapy? So yes, here also at a median follow-up of 19 months, these patients did have a 6.6% benefit in invasive disease-free survival and a 6.7% in distant relapse-free survival, and the subgroup, and this benefit was also consistent throughout all the subgroups, irrespective of the pathological breast tumor size and or the number of positive lymph nodes at surgery. The last was the 4-year efficacy outcome and an interim analysis for overall survival. This was presented on 6 December at SABC, and at a median follow-up of 42 months, the median invasive disease-free survival was not reached in either group, and but there was an absolute difference in the IDFS between the groups of 6.4%. 85.8% in the abemaciclib arm did not have a recurrence, while 79% in the endocrine therapy alone arm did not have a recurrence. So the curves again showing a benefit in the intention to treat analysis, and it persists beyond the completion of abemaciclib. Even though they had everybody had completed it at 2 years, the benefit persists at 42 months of median follow-up as well, and rather the curves separate further, so the benefit of adjuvant abemaciclib is seen even beyond stopping abemaciclib. The forest plot again showing the same in different subgroups. Coming to the safety and toxicities, so yes, we all know that abemaciclib is a slightly difficult to handle drug. There is a lot of diarrhea. 84% of the patients had experienced diarrhea. Most of them had grade 1, grade 2, but there was also reported one of the patients did die because of diarrhea, one died because of pneumonitis. There was 61% of the patients who required holding of abemaciclib for a few days or intermittently, and 43% of the patients needed a dose reduction. Discontinuation was necessary in 18.5% of the patients who were on abemaciclib. 2.5% of the patients had a serious adverse event of venous thromboembolism, and 3% of the patients had interstitial lung disease also. Other toxicities like neutropenia, fatigue, and anemia were also seen more significantly in the abemaciclib group. So the same about toxicities and 2 treatment-related deaths. To conclude, I'll say that adjuvant abemaciclib does reduce the risk of recurrence in a high-risk population if we are selecting the patient properly, and the benefit is sustained beyond the completion of treatment with an absolute increase at 4 years. So further follow-up for long-term survival benefits and overall survival benefit needs to be looked up to, and with this I'll conclude my presentation. Thank you.